Pregnancy and Breast Cancer. Green Top Guideline Number 12, March 2011. Purpose and Scope. The management of pregnancy in relation to breast cancer is multidisciplinary. Background. Breast cancer is the most common cancer in females, with a lifetime risk of 1 in 9 in the UK, and is the leading cause of death in women aged 35 to 54 years. 15% of cases are diagnosed before the age of 45 years. The prognosis of breast cancer is improving, with 5-year survival around 80% for the under 50s age group. However, the survival rate may be lower in very young women. Treatment of pregnancy-associated cancer should be in a multidisciplinary team with inclusion of the obstetric team as core members. Fewer than 10% of women diagnosed with breast cancer subsequently become pregnant, but increasing numbers of women are seeking pregnancy following treatment. Young women presenting with breast cancer often have fertility-related concerns and need well-informed discussions on fertility, pregnancy, and lactation after breast cancer and the availability of fertility preservation procedures. What is the optimal management of breast cancer diagnosed during pregnancy? Prognosis. Pregnancy itself does not appear to worsen the prognosis for women diagnosed in pregnancy compared with non-pregnant controls match for age and stage. However, as pregnancy-associated breast cancer occurs in younger population who may have features that carry a higher risk of metastasis, such as high-grade tumors and estrogen receptor negative tumors, these younger women may be expected to have an inferior prognosis. Diagnosis. Women presenting with a breast lump during pregnancy should be referred to a breast specialist team, and any imaging or further tests should be conducted in conjunction with the multidisciplinary team. Diagnosis may be difficult in women who are pregnant or lactating. Women should have a designated key worker, usually a breast care nurse. Ultrasound is used first to assess a discrete lump, but if cancer is confirmed, mammography is necessary with fetal shielding to assess the extent of disease and the contralateral breast. Tissue diagnosis is with ultrasound-guided biopsy for histology rather than cytology, as proliferative change during pregnancy renders cytology inconclusive in many women. Histology is similar to that in age-matched non-pregnant counterparts, histological grade, receptor status, and human epidermal growth factor receptor 2 or HER2 inform treatment planning. Staging for metastasis is conducted only if there is a high clinical suspicion and should comprise chest X-ray and liver ultrasound if possible. Gadolinium-enhanced magnetic resonance imaging is not recommended unless there is a specific need for it to investigate a clinical problem. Tumor markers such as CA153, CEA, and CA125 are not used in early breast cancer and may be misleading in pregnancy and are not recommended. Bone scanning and pelvic X-ray computed tomography are not recommended because of the possible effect of irradiation on the fetus. In women who are not pregnant, X-ray computed tomography or CT and isotope bone scan are the preferred methods of investigation to establish or exclude metastasis. These methods are not appropriate in women who are pregnant, in whom chest X-ray and liver ultrasound are preferred. If there is concern about bone involvement, a plain film of the relevant area and/or magnetic resonance imaging to minimize radiation exposure to the fetus is suggested. Consideration of termination of pregnancy. The decision to continue the pregnancy should be based on careful discussion of the cancer prognosis, treatment, and future fertility with the woman and her partner and the multidisciplinary team. Treatment during pregnancy. The multidisciplinary team review outcome should be forwarded to the obstetric team and family doctor. Surgical treatment, including local regional clearance, can be undertaken in all trimesters. Breast conserving surgery or mastectomy can be considered based on tumor characteristics and breast size following multidisciplinary team discussion. Reconstruction should be delayed to avoid prolonged anesthesia and to allow optimal symmetrization of the breasts after delivery. Sentinel node assessment using radioisotope scintigraphy does not cause significant uterine radiation, but blue dye is not recommended as the effect upon the fetus is unknown. Sentinel node biopsy is indicated in women who have a negative result from a preoperative axillary ultrasound and needle biopsy. If the axilla is positive, axillary clearance is indicated. Radiotherapy is contraindicated until delivery unless it is life-saving or to preserve organ function, for example, spinal cord compression. If necessary, radiotherapy can be considered with fetal shielding or, depending on gestational age, early elective delivery could be discussed. Routine breast or chest wall radiotherapy can be deferred until after delivery. Systemic chemotherapy is contraindicated in the first trimester because of a high rate of fetal abnormality, but it is safe from the second trimester and should be offered according to protocols defined by the risk of breast cancer relapse and mortality. Anthracycline regimens are safe. There are fewer data on taxanes, which should be reserved for high risk or node positive or metastatic disease. Standard antiemetics, including 5-HT3 serotonin antagonists and dexamethasone, should be used. There is no evidence for an increased rate of second trimester miscarriage or fetal growth restriction, organ dysfunction, or long-term adverse outcome with the use of chemotherapy. For women in whom tumor characteristics defined by imaging and core biopsy mean that chemotherapy is indicated, a decision may be made to offer neoadjuvant chemotherapy before surgery to allow tumor downstaging and to facilitate surgery. Occasionally, with a low-risk tumor in which chemotherapy is not indicated, there may be an indication for mastectomy. In this situation, radiotherapy would be deferred. Tamoxifen and trastuzumab are contraindicated in pregnancy and should not be used. Tamoxifen is not used until after delivery. Trastuzumab, a monoclonal antibody targeted against the human epidermal growth factor receptor 2 or NER receptor, is contraindicated during pregnancy because of reported adverse fetal outcome. There are no compelling oncological reasons for use of targeted therapies, including monoclonal antibodies or small molecule tyrosine kinase inhibitors during pregnancy, as conventional chemotherapy can be used, allowing these drugs to be reserved for postpartum. Hemopoietic growth factors such as granulocyte colony stimulating factor may be employed to ameliorate chemotherapy-induced neutropenia and have been used extensively in hematological malignancy. Their use is recommended to minimize potential maternal and fetal problems associated with neutropenia. Use of this and other drugs should be discussed with the obstetrician. Timing of delivery of the baby. The birth of the baby should be timed after discussion with the woman and the multidisciplinary team. Most women can go to full term of pregnancy and have a normal or induced delivery. If early delivery of the baby is necessary, consideration of corticosteroids for fetal lung maturation is appropriate. However, birth should be more than 2 to 3 weeks after the last chemotherapy session to allow maternal bone marrow recovery and to minimize problems with neutropenia. Lactation. Women should not breastfeed when taking trastuzumab or tamoxifen, as it is unknown whether these drugs are transmitted in breast milk. The ability to breastfeed may depend on surgery and whether major ducts have been excised. Breastfeeding while on chemotherapy is not advised, as the drugs cross into breast milk and may cause neonatal leukopenia with a risk of infection. There should be a time interval of 14 days or more from the last chemotherapy session to start of breastfeeding to allow drug clearance from breast milk. If chemotherapy is restarted, breastfeeding must cease. A short period of lactation may be psychologically beneficial after a stressful pregnancy and be beneficial to the baby. Women taking tamoxifen should not breastfeed. What are the contraceptive choices for women wishing to avoid pregnancy after treatment of breast cancer? Non-hormonal contraceptive methods are recommended. Women with a history of breast cancer should seek specialist contraceptive advice. Hormonal contraception is contraindicated in women with current or recent breast cancer or the UK Medical Eligibility Category 4. This advice does not differentiate between hormone-sensitive and hormone-insensitive tumors. Although hormonal contraception may be considered after at least 5 years free of recurrence, and current evidence allays concerns that long-term oral contraceptive use affects breast cancer risk. The levonorgestrel intrauterine system may reduce the risk of endometrial abnormalities during tamoxifen therapy, but further evidence is required on its safety in breast cancer survivors. What advice should be given to women planning pregnancy following breast cancer? Women planning a pregnancy after treatment for breast cancer should consult their clinical oncologist, breast surgeon, and obstetrician. Women on tamoxifen are advised to stop this treatment 3 months before trying to conceive because of the long half-life of the drug, and to have any routine imaging before trying to conceive to avoid the need for imaging during pregnancy. Women with metastatic disease should be advised against a further pregnancy as life expectancy is limited and treatment of metastatic disease would be compromised. Impact of pregnancy on risk of recurrence. Women can be reassured that long-term survival after breast cancer is not adversely affected by pregnancy. Since many breast cancers are estrogen receptor positive and endocrine responsive, women used to be advised against pregnancy because of concerns that it would worsen prognosis. The prognosis is good for women with a subsequent pregnancy after early-stage breast cancer. The healthy mother effect is described as the healthy women are more likely to conceive, and women with poor prognosis or early relapse do not embark upon pregnancy. The impact of pregnancy does not seem to be modified by tumor characteristics, for example, size, hormone receptor status, but there are insufficient data to draw firm conclusions. In women with breast cancer gene mutations, the risk associated with subsequent pregnancy are uncertain.